So I thought I would, I wrote a couple of notes down, clinical neurology, and I'd like to make it interactive. We're going to cover extrapyramidal disease, just the clinical aspects. Last week, I talked a little bit about the proteinopathies. These are, the old term was degenerative disease. Now, I'm going to talk about the clinical aspect. So we start with Parkinson's disease. Who can describe Parkinson's disease very briefly, like in one sentence?
Bradykinesia tremor.
Right. Basically, the hallmark of Parkinson's disease is the resting tremor, right? Resting tremor. So when the patient is not doing anything with their arms, they have a resting tremor. The tremor is very typical, usually 5 to 7 hertz, and it's pill rolling. We call it a pill rolling tremor. It affects the thumb, index finger, and it's very typical. When the patient is anxious or excited, it sometimes speeds up a little bit more or becomes more apparent. So tremor is one of the key elements. Number 2, as Dr. Acevedo said, is bradykinesia.
Bradykinesia.
Yeah, bradykinesia. The patient is stiff.
And rigidity.
And the third is rigidity.
Yeah.
And I put down something that to me is very important. It's usually not symmetric. It's not identical on the 2 sides. It's asymmetric. So asymmetry is something I look for. One side more than the other.
Different from the essential tremor.
Yeah.
So asymmetry is important. And then
symmetry.
the fifth thing is that I always try to start these patients on Sinemet or L-Dopa because in patients with Parkinson's disease, almost everybody will improve. It's a dramatic improvement. I'm very impressed. I've had patients who were incapacitated, and I put them on the Sinemet, the L-Dopa, and carbidopa combination, various combinations, and they get better. The tremor sometimes doesn't get better, but the bradykinesia gets better, the facial gets better. So to me, I like to use Sinemet as a test, not only a diagnostic test, but therapeutic as well. If a patient doesn't respond to the Sinemet, I always think to myself, it's not Parkinson's, it's some other disease. It's an extrapyramidal disease, but maybe one of the others. And we're going to talk about it. I wrote down a couple of things. Other conditions. What are the other conditions that can look like Parkinson's disease, but they don't respond to Sinemet? What are the other conditions?
MSA, PSP.
Yes, MSA, and we're going to talk about that a little bit later. What else? What about the tremor, essential tremor? Very common.
Tremor.
We will see many patients here with benign essential tremor or familial tremor.
Yeah.
How about medication related? Dr. Stein, are you familiar with drug-induced Parkinson's, drug-induced pseudo-Parkinson's?
Yes, indeed.
Antipsychotic drugs. Yeah.
Yes, antipsychotic medication.
Psychotic drugs.
And some pesticides.
Pesticides, yes, and sometimes even stroke. You can have a stroke and hemiparesis and look like bradykinesia. Also, another condition associated with copper. What is the name of that disease?
Wilson's.
Wilson disease. Wilson disease.
They can also present and look like Parkinson's, and then encephalitis. Even the SARS VO2, the SARS, the coronavirus, or other types of encephalitis can present with altered mental states, stiffness, and you're not sure. But encephalitis generally, various types of encephalitis. And then as the patient gets worse, today I got a telephone call, one of our patients He's 89. He's a doctor. And I saw him, and in my mind, I could tell that he may have Parkinson's disease, but he was becoming demented, unfortunately. And it's a colleague of mine I've known for 30 years. And so I didn't tell him that I thought he had possibly Parkinson's or a dementing illness, but now I have to kind of very gently share that with him. He's going to come and see me with his wife. I'm supposed to call around noontime today. But in patients who don't have Parkinson's, but they look like they have Parkinson's, the Sinemet frequently doesn't help. So we're talking about differential diagnosis. There is a spectrum, in my mind, there is a spectrum, clinical spectrum of Parkinson's disease, very mild to very severe. And in patients who do not respond, they have another condition. One very common condition is the drug-induced Parkinson's, pseudo-Parkinson's. And one of the most common drugs is for the stomach. Anybody know? The gastroenterologists give it to the patients for their stomach.
Metoclopramide.
Exactly, Reglan. In America, it's called Reglan, but it's a notorious medicine that can give you the pseudo Parkinson's. And you have to give the Reglan over a period of time. It's not just one pill, but over a period of time, giving Reglan weeks to months before they get the problems. Also, when you give Reglan, or when it's drug-induced or neurotoxic, it's usually symmetrical, right? It's symmetrical rather than unilateral. So think about drugs, think about Reglan. And if you keep giving the Reglan, the patient will get worse. Some patients, as they get older, they develop a gait problem. And the gait problem, the difficulty initiating gait, can look a little bit like Parkinson's. If you try a Sinemet in these elderly patients to improve their walking, they don't get better. It doesn't get better. So there is, in my mind, there is a senile form of bradykinesia that we see in older folks, especially difficulty with gait. Now, they may have gait apraxia, they may have had a stroke, they may have had something else, but L-DOPA doesn't work. So then there's a condition like my friend, I think, has, one of my colleagues, where you have bradykinesia, stiffness, difficulty walking, tremor, and dementia. What is that? What condition is that, where you have dementia together with the extrapyramidal, where you when you have combination of Parkinson's and Alzheimer's?
Dementia with the Lewy body.
Lewy body, exactly.
Yeah,
it's Lewy body
body
dementia, which
yeah.
Can be difficult clinically, but I think in my colleague, that's probably what's happening. Really no treatment for that. When you look at the pathology, when you cut the brain, in China, do you do brain cutting every week in the hospital? Cutting brain? Okay. In the United States, in many schools, we are used to doing a brain cutting where we have the history, physical exam, laboratory studies, and we actually see the brain, the pathology. 24% of patients who have been diagnosed with Parkinson's disease don't have the pathology. So it's very high. The misdiagnosis is very high. But in my estimation, if I see a patient with extrapyramidal disorder and I can use some Sinemet, I will do it because it's not only diagnostic for me, but therapeutic. A few years ago, we used to teach the students, don't use the Cinemet, don't use the L-Dopa. Wait with the L-Dopa, wait for, use it at the end. I said, why? What are you waiting for? But there was a theory, do you remember that, Dr. Stein? There was a theory 30 years ago to use the dopamine agonist, to use other agents, which I don't think work, by the way. The best medicine is the Cinemet. But they used to tell us, don't use it, wait, almost like a gold. Use it only if you go, at the end. I said, what are you waiting for? In America, the Cinemet is very cheap, by the way. It's very inexpensive. And for me, I use it as a therapeutic tool, but also diagnostic tool. So the other conditions, and I put a couple of notes here. One of them is PSP. Who knows what that is? PSP.
Progressive supranuclear palsy.
Okay, can you tell us a little bit about it?
So the presentation is similar to Parkinson with the tremors, gait abnormalities, fatigue, headache, arthralgia, depression. But the neurological symptoms you have is like Parkinsonism syndromes, dystonia, ophthalmoplegia, ocular symptoms, behavioral cognitive symptoms, and you have like gait abnormalities, frequent falls. So those are the symptoms that you can have with progressive supranuclear palsy.
Yes, the PSP is an interesting
The PSP is characterized by the eye up down is difficult.
Yes.
And the extremity is rigidity, and the trunk is difficult rigidity, and the second core is frequently fall down.
Yes.
So
they fall down, right? They fall down.
Yeah.
And remember that the eye movement problem is a vertical problem,
difficult.
especially looking down. So they usually fall when they are walking down the stairs. Less likely to walk up the stairs. More likely when they fall downstairs.
Yeah.
And
more rapidly progression than Parkinson's disease.
So now, PSP, originally described by Steele, Richardson, Olszewski, neurologists, University of Toronto in Canada, in Ontario. And this is a beautiful paper that they wrote, and they described the pathology. And one of the hallmarks of PSP is that these patients can use their fingers, right? But they cannot use, they have a problem with the body, postural problems. They tend to fall. Also, they have eye problems. So when you see them, you can differentiate that from the usual Parkinson's disease. They have a lot of staring, they're staring. They have postural, and they have rigidity. They are extremely rigid. And they have the visual problem, especially looking down, supranuclear palsy. They also, if you check the eyes, they have abnormal saccadic movements. They cannot follow the finger smoothly. They have a disruption in saccadic eye movements. They have difficulty walking, and they have difficulty swallowing. So they usually come in there thin. They end up in the bed. What is the pathology in PSP? What is the pathology when you cut the brain? Usually.
The top protein.
Exactly.
Top protein. The top protein is unlike Parkinson's disease. Parkinson's disease is alpha-synuclein protein.
Yes, and they have tau protein. Right? And they also have abnormal neurofibrillary tangles as well. So they do have the tangles, and they have the tau. So the pathology can look similar to, let's say,
Also,
Alzheimer as well.
Yeah.
So after the PSP, somebody mentioned multi-system atrophy, MSA. Who can tell me about MSA?
Strong
MSA.
autonomic symptoms and a rapid progress sometimes.
Sometimes, because in MSA, I had a patient that went for 10 years with MSA.
Yeah.
So I remember that it can last a long time. Initially, the MSA patients are always diagnosed with Parkinson's disease. They're frequently put on Cinemet. They put on L-Dopa. They don't get better. And, and what happens because of their rigidity and their autonomic disturbance, they end up in the bed. They end up in bed like this, stiff. And you try to examine them, they have bradykinesia, they have stiffness, and they have autonomic problems. Some patients
autonomous problem and ataxia and Parkinson. Let's try it.
And they also, the men, many of the men who come in, they have, they're impotent. They have sex, no sex. They, because of the autonomic disturbances, they have difficulty with erection. So impotency, sometimes they come in with impotency. They also lose their urine. They have urinary incontinence. And frequently they faint. We have an autonomic center in our Alexandria. We are very interested in neurotology and we do electronystagmography and balance. We like to check these patients. They have orthostatic hypotension and frequently they faint. Sometimes these patients are lying there. They can get jerking. They can get myoclonus. So myoclonus is, on examination, they have frequently Babinski, they have hyperreflexia, they have pyramidal tract findings, and they can be ataxic as well, especially earlier.
Yes,
so cerebellar findings
that
as
is
well.
with the olivopontocerebellar atrophy and striational striation degeneration. Shy-Drager, it used to be called Shy-Drager syndrome.
Shy-Drager is part of the differential diagnosis.
Yes.
Shy was a very famous neurologist in Harvard, Milton Shy. He was I'm much younger than he was. He's dead now, but he died early. But everybody I spoke to who knew him, I never knew him. He was always considered a very fine person, a wonderful neurologist. Milton Shy. I understand his son is also a neurologist. But anyways, the Shy-Drager is part of that in the differential diagnosis in the MSA. Another one is striatal nigral degeneration. We call it striatal nigral degeneration. Very difficult to separate clinically, in my estimation, very rare. There's a degeneration in the striatum, and it can look like MSA. The other one, somebody mentioned, I think you mentioned olivopontocerebellar degeneration.
Yes.
Also part of the whole syndrome, and these have a lot of cerebellar findings. Now, in MSA, it's very rare to have it before the age of 40. So we don't see younger people with it. And it's rare to have it over the age of 60 unless it's not diagnosed. So it's between 40 and 60 usually in terms of diagnosis, 50 to 60.
Dr. Bernad, also
patient,
there is psychiatric condition, difficulty controlling emotions such as laughing.
Yeah, well, the pseudobulbar, what we call pseudobulbar state, is also part of it, like in Parkinson's as well.
Part of the autonomic that you stated, they have cold hands and feet.
The MSA patients, I had a patient with MSA went for 10 years. They can go for many years. And most of the time, it depends on who's taking care of them. This patient was a patient who lived in the Watergate and was quite famous. And they asked me to see him. But he had excellent care, day and night care. 2 loving daughters, and they were wealthy. They could afford the excellent care, frequent turning. When I was seeing it was very stiff. They usually die from pneumonia, aspiration and pneumonia.
Yeah.
And you know, somebody like this they live in the nursing home, and if they get the SARS virus, of course, there's no hope. I mean, they're dead. They're frequently on a respirator, and but there's no known treatment. In MSA, by the way, they have good eye movements, so that's one of the differential diagnoses. The MSA is different from PSP. In MSA, they maintain their eye movements, and usually there's symmetrical onset, unlike in Parkinson's, which is asymmetric. The stiffness and rigidity is symmetrical. They don't usually have a tremor. The resting tremor is atypical, is unusual in MSA. And initially, we give the Cinemet, we give the L-DOPA, and it may help a little bit. It may help initially, but after a while, it loses its efficacy. And they usually develop stridor, inspiratory stridor when they're breathing. Almost all of them end up with the tracheostomy. They can also have myoclonus. They can have myoclonus too. And in the pathology, they can have inclusion bodies in the oligodendroglial cells. They have cell loss. They have gliosis in the striatum. Okay, then another very rare condition is corticobasal ganglionic degeneration, corticobasal. These are akinetic. They are almost no movement at all, akinetic. They are unstable. They lose their ability to walk. They can have dystonia, limb dystonia, and they walk backwards, retropulsion. They can have myoclonus. When you tap their reflexes, there's a jerk. They have abnormal cerebellar finding, dysdiadochokinesia, and they are apraxic. They have a lot of cortical signs, sensory loss, frontal release, and apraxia. They can be also dystonic. They have a lot of cortical problems, Dr. Stein. They have this alien limb. Are you familiar with that?
Yep, yeah.
Alien limb. They may look at their arms and not recognize it. They have dysarthria, dysphagia. And remember, asymmetric signs. Very slow onset, insidious. And they have neuronal swellings. But in my mind, I don't think I'm able to diagnose clinically the corticobasal ganglionic degeneration. You have to see a lot of patients like that to be able to differentiate from other extrapyramidal disorders. Okay, I just put these down. If anybody's interested, there's a Lancet in 2015 that has reviews, but almost every journal will have nice reviews on extrapyramidal disorders. They are fascinating to me, very interesting conditions. And they are generally considered part of that movement disorder. And here in America, you can do a fellowship in movement disorders and have a clinic devoted totally on movement disorder. At the NIH, we used to have a clinic for movement disorder. Dr. Stein, any questions?
Excuse me, Dr. Bernard.
Yes.
I have one question. Yeah. How about the REM sleep behavioral disorder? Is it a red flag for MSA patient?
Yes. Yeah, the rapid eye movement, sleep disturbance, behavioral disturbance is something that we are very interested in because we recognize that even 10 years before, 10, 15 years before the diagnosis of Parkinson's disease, the sleep study is positive for these unusual and bizarre behavioral changes associated with REM sleep, with rapid eye movement sleep. Frequently, the wife tells me that the husband hit her, kicked her. I had a patient, it was a big guy, 300 pounds, 350 pounds, 180 kilograms, huge guy. And he would have this terrible dream during rapid eye movement sleep, jump up and down. And the wife was very small. She was tiny. The husband was very big. And he would almost kill her. He would jump up and land on her. And they came in to see me. And I followed them. I separated them. I told them one had to sleep in another room. I put some Klonopin. And then he turned out to have Parkinson's disease a few years later. So you can have a behavioral disturbance during REM sleep. We always ask about that. A major study was done with Mayo Clinic and McGill University, published last year, showing that you can predict almost to 90%, unbelievable concordance with REM behavioral disturbance and subsequent Parkinson's disease. Almost no other diseases where you have such a close relationship. What about in China? Do you see this REM sleep behavior and Parkinson's disease?
Yeah. In China, no motor syndrome is very common. The most common before Parkinson no motor syndrome occurs. So as Dr. Bernad said, constipation, insomnia, or RBD, and hypoxia is very common. Yeah. So,
I think that's a good point. That we used to emphasize 30 years ago. We would emphasize the movement problems, the tremor, the stiffness, motor. Now we are finding that they have cognitive problems. They have autonomic problems. There are emotional problems, depression, sleep problems, and so forth. So you're absolutely right that the emphasis in the research on Parkinson's disease is now non-motor. It's not the motor components. It's all the other, the psychiatric, the emotional problems, the cognitive problems, the dementia, and so forth.
So the early stage, the Parkinson's disease or early stage, the diagnosis is very difficult. So if the patient suffered from Parkinson's disease in early stage, we consider it as some no motor syndrome. For example, RBD or hypoxia is very important sign for diagnosis of Parkinson's disease.
You're looking for it in the history. Thank you. That's very good. Yes, good point. Anybody else with any other points that?
Bernard, I have a question.
Sure.
Now for the patient of younger patients in PD, we choose the medicine. We choose levodopa or choose the receptor agonist because have some papers said use levodopa will cause the medicine's tolerance and cause maybe the late stage we use these medicines have no effect.
That's the old theory. And
Yes.
I agree with that because my teachers also used to say that save the L-DOPA, use the agonist, use the skin, use this, use that. So I say why. They talk about tolerance, they talk about receptor changes. But for me, why not give the patient quality of life early? Why wait? I mean, and also many people don't believe that the agonists really work. I mean, I think there's some evidence that it may also cause problems. So
Yes.
I like to use the Sinemet early because I use it as a diagnostic tool as well. So both therapeutic and diagnostic tool. We now have imaging. So we're using different kinds of imaging, PET scanning, and we're using other diagnostic studies, but then I don't think they're as helpful as using a chemical diagnosis and seeing an improvement. If you have a patient with Parkinson's disease and you treat them with a Sinemet and they improve, very good chance that this is Parkinson's disease. And if they don't improve, I think it's a good chance they don't have Parkinson's disease. So you think about other diagnoses in the differential, but you know, there's a variability in terms of approach. And I think you have to have an open mind. But that's the extrapyramidal. Dr. Stein, we talked about the proteinopathies last time. Remember we could add this, I can do this again later, add that into the taping.
Okay, thank you.
But thank you, everybody.
Thank you.
We'll bring the next patient, okay?